Hey everybody, how are you guys doing? Sorry, I've been the lurker in the back of your room today. um, but I wanted to hear everybody's talks this morning. They were really good. So hopefully I won't disappoint with this last one before lunch and I can keep you a little entertained. Okay. So I'm Stephanie Keller. I'm a pediatric neurologist in Atlanta at Emory University. So if you're asking about adults, I probably don't know that much stuff, but hopefully I can help you out with the kids a little bit. Today we're going to be talking about forecasting interventions for pediatric patients. So I'm not going to talk about interventions like gene therapies or bone marrow transplant or stem cell transplant. Those things are going to be covered in other talks today. We're just going to talk about mainly things that you might come across as far as kind of treatment interventions or testing or things like that that your patients might or your kids might have. So these are just my disclosures. And so one thing I just wanted to kind of start off the talk by saying is that leukodystrophies are all very different. You guys know that very well. And even within certain leukodystrophies, kids can be different. So everything we're going to talk about today doesn't necessarily mean these are all things that your kids are going to need. It doesn't mean there are symptoms that your kids are all going to have. So you definitely want to, talk to your treating physicians. They're the ones that are going to know your child the best to see if these things might be right for your child. So again, interventions, just kind of classifying that as procedures or equipment that may be helpful based on your symptoms, and to hopefully help prevent some complications or kind of treat some complications that you might have as far as the disease. We'll kind of break it down a little bit and maybe the specialists that you might see for these things. So for neurology, I'll discuss briefly some EEGs and EMGs and kind of what those tests are. Pulmonology, sleep study, BiPAP, vest physiotherapy, cough assist. We'll kind of talk about a few of these things. And again, this is coming from a neurologist. So if you want in-depth stuff on this, you probably want to talk to a pulmonologist. But physiatry, this overlaps a little bit with neurology, so we'll talk about some of those therapies for spasticity and kind of movement disorders. Orthopedics, I won't really go into it too much. We'll talk a little bit, but some bracing and orthotics. I heard some people talking about earlier, kind of spinal surgeries. I won't really go into that, but definitely have an orthopedist on your team is a good thing. And then we'll touch on a little bit also GI. I know some people were talking about G tubes and PEG tubes and NG tubes, things like that. So we'll touch on that briefly as well. So for pulmonology, those are just the doctors that help with breathing. And with leukodystrophies, because the kids have a lot of weakness and also their brain involved, they may have difficulty with breathing or handling their secretions that can then affect their breathing. And this can be a big thing in leukodystrophies as far as quality of life. We can have a lot of hospitalizations for breathing issues. It can also be something that causes end of life as well as when kids have breathing issues. So having a pulmonologist is really important, but there are some things that they'll probably talk about with you guys. So big things are secretion management or just kind of drooling. So if they're having problems swallowing, they may have more problems with drooling. Sometimes just developmentally, some kids need help with kind of that reminder to swallow and deal with their secretions. But that can affect their breathing. If they're having a lot of secretions at night, the kids may cough. They may be at risk for aspirating if they're not dealing with their secretions well. Kind of one of the first things we usually look at to help with that would be medications. So there's several different options. One is glycopyrrolate or Robenal. You guys have probably heard a lot about atropine drops, or it's actually an eye drop that we use under the tongue that can help with secretions. And then the scopolamine patch is another one also that can be used. So that's kind of our first line when we start thinking about secretions or medications. Sometimes those can have side effects though that are not great for the kids. Like sometimes kids may have more constipation with it. That can be a problem with certain of these medications. Some kids haven't tolerated the scopolamine patch just because of the adhesive on the patch for some of my kids. A lot of kids have home suction, but that's not the greatest thing if you're having to suction constantly. So then they start thinking about other procedures, and these things are usually done with an ear, nose, and throat doctor or a physiatrist. That you can get actually Botox to the salivary glands. You guys have probably heard of Botox. Of course, for ladies' wrinkles, one of those things, though, it kind of relaxes muscles, but we'll talk about a little bit later. Botox is also something that can be used for stiff muscles, but they can actually use it in the salivary glands to kind of decrease the production of saliva there. And again, that's usually done by ENT or through physiatry. The other thing, though, that kids can have done is actually surgery on their ducts that produce the saliva. So the salivary glands and the parotid glands, they can either sometimes take them out or they'll kind of ligate them so they don't produce as much. But that's usually, again, after we've kind of failed medications for different reasons. And then, for going back to kind of respiratory, there's a lot that can be done just with positioning and stretching to make sure that we keep those lungs in a good, healthy environment, basically. So sometimes if our kids aren't sitting up well, they can develop scoliosis. And so because of that weakness, they'll kind of lean to a side. And if they do that, they can kind of collapse that lung a little bit, and that can affect their breathing. So managing scoliosis isn't just for the cosmetic benefit that we want you to be upright and straight. It really kind of helps out with the respiratory as well. The other thing would be stretching. Sometimes the kids get very tight in their chest areas, they kind of collapse in that position. And so working with your physical therapist, they can teach you some exercises to kind of stretch out the chest. Again, kind of helping to keep that room for the lungs there to breathe and open up appropriately. And then, again, your pulmonologist may recommend some treatments like albuterol and Atrovent, or things that can be used through a nebulizer or an inhaler to help out periodically if the kids are having some difficulty during illnesses, or some kids use it on a regular basis more for maintenance. Atrovent is an inhaled treatment, but that can also help with secretions sometimes too. And then there's some other things. So high frequency chest wall oscillation. So that would be the first picture up there. Do I have a thing? Oh, look. So this would be here. And thank you to all the little kids that I stole their pictures off the internet. These are not my pictures. Um, these are company pictures mostly. But so it's a vest that they wear, and then it attaches to this machine. There are some that are more kind of battery operated, but it just kind of shakes their chest. And so it can help kind of loosen up secretions and things when the kids are having difficulty, that maybe they've got some weakness. So it's harder to kind of cough up all those secretions and get those things out. So this just kind of helps that out. Kind of like patting somebody on the back, but this is a really good pat to kind of shake everything out. And then you can also have things called cough assist, which I don't have a picture here. But again, for those kids that have that weak cough, so we kind of loosen some things up, but then it's harder for them to kind of get it out. So the cough assist actually has kind of pressures where it kind of pushes and pulls things, pressures out. So you can help them get the cough out, basically. It's helping them to cough. So cough assist. And those are things that your pulmonologist will let you know when they think is appropriate for your child. But these things can be really good, not just at the time of an illness when maybe they have more secretions, but for some kids, it's really helpful as sort of a maintenance to help prevent them from getting pneumonias or things like that when they get sick, kind of keeping their lungs clear. And you can see down here, actually, this is a little cough assist here. It's a little math there. And then the last things would be sleep studies. I know there was some talk about sleep studies in the room. I sit back there listening, I'm sorry. So basically sleep apnea is something that can occur with our kids as well. Your brain tells you how to do everything, and it tells you how to breathe at night as well. And so that's something that can occur. Also, one thing is that we have airways that when they get weak, then they can kind of collapse. So basically our palate and everything that usually are held open to allow air in and out appropriately. When we get weak, those can get kind of floppy, and the kids can get what's called obstructive sleep apnea. So that can occur as well. And so signs that they may be having problems with sleep apnea would be, waking up at night, if you're hearing little pauses in their breathing, bedwetting, kids that are more verbal, if they're having like morning headaches. So these are all things that if you're hearing, kind of snoring is the big thing, but a lot of us can snore and it's not necessarily sleep apnea, but that's kind of one of the first indications there. But if you're hearing that where they kind of snore and then pause, that you probably heard, that can be sleep apnea. And so a sleep study would be then what your doctor would recommend to kind of really test for that and see if they really have sleep apnea. And if they do, then there can be treatments that can be done at that time, things like BiPAP or CPAP that can help kind of keep that airway open at night. And it's really important because if they're not sleeping well at night, then that can affect their mood during the day. It can affect having seizures if they're not sleeping well. It can affect their learning. So it's really important to have good sleep for all of us. Also during an EEG, one thing during a sleep study, I just wanted to mention is that they do a partial EEG during a sleep study. So kind of records their brain waves. It kind of helps them just interpreting the sleep study because your brain waves do change in sleep. But, for some of our kids that are at risk for seizures, it does give a little glimpse of that as well. Like, could they be having some seizures in their sleep? And so sometimes if your child has epilepsy or there's some concern and you're going to have a sleep study, they can do what's called a full EEG montage where they can kind of get the full EEG, which really gives your neurologist more information than just the partial one that they normally get. And so that's something that can be arranged. So you just kind of want to ask for that if that's occurring for your child. Oops. Um, and then talking about also kind of the kind of more treatment for breathing would be oxygen, of course. Oxygen can be given through a mask. It can also be given through a nasal cannula. And this is a little example of a nasal cannula here. Um, and BiPAP is the one, again, where it really kind of helps open that airway or keep that airway open. A lot of times it's used more during sleep. Sometimes when kids get more progressed into their disease, sometimes they're requiring BiPAP for longer periods during the day. And then there comes some discussion, typically at that time, about quality of life if they're requiring to be on this BiPAP more continuously. But typically, it's used more just during sleep. And it's usually more of a mask, but they've got smaller ones now that they're getting fancy. They're getting more comfortable over time. But for some kids, it can be a little bit uncomfortable and kind of take some time getting used to that mask. And then there's also tracheostomy. So this can be for airway protection and prevention. So a lot of our kids that have a lot of those difficulties with secretions and they get sick and then they're in a hospital frequently, they're requiring intubation, they're having problems protecting their airway, basically. They're having a lot of aspiration. Then at some point they might talk to you about a tracheostomy. And so that's where, like, this little girl here, they have the little tube in the throat here that's going to hopefully then kind of bypass the problems with secretions as far as keeping that airway protected, that there's not other things going down into that airway. Now, that's a big procedure. That's a big decision. Sometimes it's used with a ventilator if they need that. Again, sometimes it's just there more for airway protection and they don't necessarily need it for ventilator purposes. But it requires like a 2 to 4 week hospital stay, getting a ventilator or getting a tracheostomy placed. So it's a big decision and requires a lot of kind of talking with your team, kind of about your goals for your child and whether or not you feel like that's the best treatment course for your child. And then again, there's ventilators also, kind of when you start getting to the point where you're talking about a tracheostomy. Again, this is usually if you've had multiple hospitalizations for frequent pulmonary infections, that the child is coming in and out of the hospital frequently, requiring a ventilator, requiring a lot of respiratory support. And that would maybe start talking about, tracheostomy and if they need the ventilator support. And so ventilator support can be life prolonging, but I think one thing to remember is it doesn't necessarily cure the underlying disease. So the children will continue to have neurologic decline, but they're on a ventilator that's supporting their continued life. So again, at that time, there's a lot of conversations about kind of what your goals are for your child. And for some families, they're very happy that they did a ventilator. For some families, that's not the route they wanted to go for their child. So it's individual for everybody and takes a lot of consideration. It again is a longer hospitalization for putting in the tracheostomy and getting them used to the ventilator, getting everybody trained on a ventilator, getting nursing at home kind of arranged to help you with that as well. They do have ventilators that are portable, so they're smaller. They're not like the big ones that you have in the hospital. But it does in some ways kind of limit interaction for some families because they've got, attached to a ventilator. So for some of my families, that was one of their considerations about whether or not they wanted to go down the route of having a ventilator for their child. And to go over some GI stuff, again, we're taking this all in perspective from a neurologist. You should definitely have a GI doctor on your team as well. And so the biggest thing that GI, there can be a lot of GI issues in leukodystrophies. There are a lot of nerves in the gut as well. So a lot of kids can have problems with not just feeding, but like tolerance of feed. So it's a really good idea to have a GI doctor on your team as well. But one of the big things as far as procedures that we talk about are things that would help with feeding. I will say I've seen a lot of my kids have sometimes had a loss in interest of feeding before they've actually lost the abilities to feed. So sometimes if they're just not keeping up with the amount of calories that they need to grow, if you're seeing some drop off there, then sometimes that's when we start thinking about a feeding tube, even though they may physically still be able to take safely some food in. But again, there may also be a point where the kids have difficulty with their feeding physically, that they may be aspirating, not getting the food kind of safely down into their stomach, that it may be going more into the lungs. Some signs of that is they can have like coughing or gagging when they eat, or sometimes they'll describe that they sound kind of gurgly or wet after they eat. Those may be signs that they're kind of aspirating, that the food's not going in the right direction. If also, again, if they're kind of having a lot of drooling, that may be a sign that they're not swallowing very well. If they're not handling their own secretions, then they may not be able to handle eating as well either. So one of the first tests that we usually do an evaluation of that would be a barium swallow, and there's usually a therapist that looks at how they're swallowing as well. So with the barium swallow, they usually swallow different thicknesses or consistencies of barium to see how they're handling each one of those. And with the x-rays, they can see it, make sure that it's going in the right direction, basically that barium that's going down the stomach, that it's not kind of coming back and aspirating at any of those different thicknesses. And then you have the therapist there who's kind of watching how they feed also. And they may make some recommendations then based on that test. So sometimes it can be a problem with the position that the kids are in when they're eating. So, like all of us, if we try to eat when we're laying down, we're probably going to aspirate a little bit ourselves and choke on it. So sometimes if our kids have poor head control or neck control, then they might not be in the best position when they're trying to eat. And so they may be more likely to kind of aspirate. So the therapist may recommend, kind of feeding them in certain positions. Based on the barium swallow, they may say, well, your child maybe had some aspiration with the thin liquids, but on the thicker liquids, they did okay. So we can do something called thickening to a certain consistency. They usually give you some consistency like, honey or something like that. And there's these thickeners that you can add to thinner liquids to kind of bring them up to that consistency so it's safer to swallow. And again, in the more severe kids that maybe they're aspirating on all those different consistencies, or they don't think it's safe for them to swallow, then they might start talking about tube feeding. And so as far as tube feeding, kind of one of the first ones a lot of people hear about would be an NG tube or nasogastric tube. And this is where we have the tube that goes in through the nose and then down into the stomach for the food. And so this is really a temporary procedure though, meant to be temporary. Because it's something that's just kind of taped to the face in place and going through the nose. And so the problems there would be that it can come out frequently. And so the families are having to do some frequent trips to the ER to make sure the tube is placed correctly in the right spot. We can have irritation if it's been in there for a long time, irritation to the nose. They can also have, irritation from the tape they're having to constantly have on their face. So it's hard for something to be something that's left for a while. I know a lot of people get scared when they start talking about like a permanent tube that's surgically placed, but I feel like this is not a good long-term thing either because it's very uncomfortable. And unfortunately, if we know we have a progressive disease, that it's unlikely that that feeding is going to come back or improve, it may be good just to kind of skip this step and to go for a surgically placed tube. Again, this is more if you have like a temporary condition that you think is going to improve. So it might be used in a situation like maybe if your child gets sick and they're having more problems at that time, it might be something that's used temporarily. But if we think it's more related to kind of progression of disease, it might be better just a more permanent option. But this can help provide nutrition, making sure they're getting their adequate calories in, making sure they're growing well, making sure they're getting their hydration, definitely when they're sick and it's harder to get anything in them. And you can also get your medicines in that way. And again, with this, it can be removed, so it's not a permanent thing, of course. And then to talk about the more kind of permanent options would be the G tubes or a GJ tube. And the difference there would just be when we have a G tube, we have the tube that's going from the outside of the stomach directly into the stomach. And it's got a little balloon here on the inside of the stomach to help keep it in place. Whereas a GJ tube, the tube extends a little farther past the stomach. Sometimes that can be helpful if the kids have more reflux, then the GJ tube can kind of help because it's kind of dumping the nutrition a little bit farther down the line, so it's less likely to come back. Um, talking with your doctor about which one they think would be the best. Sometimes there's some question about absorption of medicines from the jejunum. Medicines typically absorb better in the stomach. Sometimes they have some where they have a port into the stomach and a port into the jejunum. So you can kind of give medicines one way, kind of give food another way. But these do require surgical placement. And so there's always the risk there that you can have infections, you can have pain. It's usually pretty temporary. I feel like the pain, I feel like most kids do pretty well with it. I've had a couple of kids that have had kind of more ongoing issues with it and required some medicine. They can also sort of have leakage of some of the stomach juices, basically, and that can cause some irritation to the skin. Some kids can also develop some granulation tissue, which is basically like some scar tissue kind of build up around the site of the G tube. And the GI doctors do have ways to kind of deal with all of those things. So, but those are kind of possible complications from it. And they can come out sometimes too. Sometimes, unfortunately, kids will yank those things out. They'll yank anything that's around them, unfortunately. And so sometimes those have to be replaced as well. I think one thing to mention here with this is even though it's surgical and it is a little more kind of permanent than the tube through the nose, it still is something that can be taken out and can be reversed. So we have kids that have, had to have a G tube for a while and then they've been doing well and not needing to use it as much and then it's taken out. So it's not an absolutely forever thing once you have one. So it's transitioning over to neurology a little bit. So if your child has any concern about seizures, or sometimes just in the evaluation process for treatments for, if they're going to go through transplant or some gene therapy or something like that, they might end up having an EEG. So an EEG is a brainwave test, basically. We put these little stickers on their head and we kind of look at the kind of electrical information that's coming off their brain. And we get these little squiggly lines. And as neurologists, we're taught to interpret these little squiggly lines. There can still be some subjectivity about it. Sometimes you can have two doctors kind of both look at those squiggly lines and they may have a little bit of disagreement, but most of the time we agree, I feel like. But this can help us see if kids have any tendency for seizures or if they're actually having seizures. Sometimes kids can do funny things, and for us, it can be difficult to know if that's a seizure or not. So we'll get an EEG to try to capture those spells and tell us if it really looks like a seizure that they need medications for. Sometimes if the kids have had some decline or they're, not acting themselves, and sometimes we'll get an EEG to look and see if it looks like they could be having some silent seizures that we need to treat that could be causing them to act differently. There's different kinds of EEGs, which basically are just separated based on how long the EEG goes for. So the basic one is a routine EEG, which is about a 20 to 30-minute test in the office. And then there are some that will go for hours. There are some that will go for days. The longer ones we typically do as stays in the hospital where you stay overnight for a couple of days. That's a lot of times if we're trying to capture a spell or something funny that they're doing. We also have ambulatory EEGs, meaning they put you on an EEG and they send you home with it. The difficult thing is the EEGs are pretty sensitive. We're looking for these little tiny brain waves on the skull. And so it's having to travel through the tissue and fluid and bone and everything. So that just to say it's a very delicate little connection there that we're trying to look at. And so if the kids kind of scratch their heads or pull at something, then they're going to lose that little connection for us. And then we don't get our good clear squiggly lines. And so it's hard to interpret. So if you have a child that's going to pull at their head a lot, probably getting it at home is not going to be the best option. Also in neurology, something that we do sometimes is an EMG or nerve conduction study. And so with this, it's looking at the function of the nerves. For those of you who are here this morning, Dr. Fatimi did a good explanation about the nerves, coming from the brain to the spinal cord and then out into our limbs, to our muscles and our arms and legs. And with a lot of leukodystrophies, they can have effect on those nerves from coming from the spine to our arms and legs. And so sometimes you might have an evaluation either during the diagnosis process, or again, if you're going for some sort of treatment like a transplant or gene therapy, this may be part of the evaluation process. Or say if the kids are having some new symptoms that seem to go along with a neuropathy, then they might do this test to kind of evaluate for it. So neuropathy symptoms are usually, they can be problems with your walking or weakness. It can also have problems with sensation, like they could have some numbness. So those kind of symptoms often go along with neuropathy. Sometimes on the doctor's exam too, they can see signs of changes in their reflexes that can give an indication that maybe there's a neuropathy there. And so with this, basically, they are using electricity to move down that nerve and kind of see how long it takes to get that message or electricity from one spot where a nerve is to another spot, and to see if there's any problem with how that information gets passed along that nerve that could indicate there's a problem with the nerve there. So is there any kind of blockage in the information traveling from one spot to another? And so I will tell you, I've had this a few times myself. It's not the most comfortable test. Because they send like a little shock, little quick shock. So it's almost like a pinch, like you want to be like, quit it, don't do that. It's not the worst pain in the world. Repeated over and over again, it can get kind of uncomfortable, but it's more you just want to be like, stop it. I used to say it was like when we used to put a battery to our tongue when we were little, but you guys are getting too young for me and nobody does that anymore. So I can't help you there. But if you want to go home and put a 9-volt to your tongue, that's what I want to taste or what it feels like. But I don't recommend it. So anyway, it can kind of be an uncomfortable test. So we usually don't do it unless we really need that information for something, if we're going to use that purposely. So it's not a test we do just for monitoring in general. So bracing and orthotics are, again, not, I guess, technically not an intervention, but I think they're a big part of, helping to make sure the children do well. So there are different types of orthotics or braces. So this one is one kind of a lot of our younger children have, would be SMOs. And basically there's SMOs and AFOs, and the initials there are basically just talking about kind of what part of the leg they're helping to support. The SMOs are these little short ones that just go around the ankle. And that's a lot for our kids that have low tone and they have kind of these floppy ankles that kind of collapse a bit to the inside. And so the AFOs can really help support that ankle and help them walk better. And then we have the taller ones, the AFOs, which go up higher, like just below the knee. You can see this one's got a little hinge in it, where this little girl's, I don't think hers has a hinge. So you can have them either both way. These are often kind of more, these are a little bit as well, but these are often molded to the patient themselves, trying to get the best fit for them. But there can also be a lot of things that need done as far as adjustments, even after they've been, molded for that patient in particular. The AFOs are good for kids that have weakness. It does support the ankle, kind of like the SMOs, but if the kids have some weakness also in their legs, so they kind of got those floppy knees as well, this can provide a little bit more support for that, so they're not kind of collapsing like they might in the SMOs. These can also be good for kids that walk on their toes, because it kind of limits that ability to walk on your toes because you're in that kind of right angle position. And if kids have increased tone, like they often do when they're walking on their toes, it can also provide a good stretch for their ankles. Because, if you've had a child who's got increased tone, the doctor's always probably telling you to stretch their ankles, or the therapist. And it's something you can't do all day, every day, right? So if they're in an AFO, it's going to provide some support for them through the time that they're wearing it during the day. And so this is all, it's, putting your child's foot in the right position for walking and stabilizing them. So even though when your kids aren't walking, it can be good because, again, it still provides that stretch for their ankles, and can be helpful if they're still getting up into other equipment that we'll talk about, like standers and gait trainers. It's really good to have good bracing for them for those things as well. So when we talk about, the increased tone or that stiffness, we're often talking about like hypertonia, spasticity, or something else called dystonia. Dystonia is a movement disorder, but it looks like this kind of stiffening and twisting that can occur sometimes. Sometimes the kids are walking on their toes because of a dystonia, but it goes along often with some of our leukodystrophies and can also happen with spasticity. So sometimes they'll have kind of combinations of the two. But the first line we usually do is for treatment for these things can be medications. And so the advantage of doing an oral medication would be that they're not invasive. It's not a permanent kind of treatment. So if there's a problem with their effects from that, it's going to wear off because it's a medicine. Some of the difficulties, though, is that sometimes it's hard to achieve a steady state, meaning that if we're taking a dose here and taking a dose here, then sometimes there's some drop off in the times between based on how the medicine's being metabolized instead of kind of being at the same kind of level of effectiveness all the time. It can also be hard that some of these medications are taken multiple times a day, like 3 times a day to really be effective. And sometimes that's just hard kind of to get 3 times a day in a medication. They can also sometimes make the kids kind of drowsy, which is probably the biggest side effect that I hear of and that people don't like with the medicines is that they can make them sleepy. Sometimes after the first couple weeks on the medicine, they're not as sleepy or affected by it, but that's probably one of the big things. Also, the medicines, they are a muscle relaxer and they're not targeting a certain muscle. So some of your kids may have actually kind of weakness in like their trunk muscles, but maybe they've got stiffness in the leg muscles. Well, this medicine's not really going to pick just the leg muscles to affect. And so sometimes they can actually have more problems with their areas of their body that are weak when they get on these medications. Not always, but sometimes we can see that. And the common medications that we use for this are kind of these listed here. Baclofen is probably one of the ones we use most commonly. Also, diazepam and clonazepam are both in the benzodiazepine family. Those are used a lot. Tizanidine, dantrolene, gabapentin helps a little bit with some of the stiffness. It can also help out a little bit with movement disorders as well. And then Artane is one that's kind of more for some dystonia. Again, a lot of these medicines can make the kids sleepy. That's the biggest downside to them. Sometimes, like Artane can also cause some constipation or problems with gut motility. It can sometimes be used as a benefit, though, in kids that have a lot of trouble with drooling because it can kind of dry up some oral secretions as well. So sometimes you can use a side effect to your advantage. Also in that same light, if the kids are having like problems with, waking up at night and it seems to be because they're having some muscle cramps or stiffness, then using one of your muscle relaxers at night can help them sleep and also help with those muscles. But so if we have problems with tolerating the medicines or say the medicines are just not enough for the symptoms that they're having, like the stiffness that they're having, then they start looking at these chemodenervation treatments. So those would be Botox, something called phenol, and alcohol. So these are injectable medications. And the good thing there is that it's also not permanent. The effects kind of last for so many months. It's kind of different between the different treatments, but they can overall help to improve the joint range of motion and position. It can help with gait if they're kind of limited because of their stiffness. Like some kids, their legs will cross a lot, and that can be a problem with trying to just dress them or change their diaper. And so using these injectables can help out. And it's nice because unlike the oral medications that don't pick a medicine, this you're directly picking the muscles that you want to address. And then so the disadvantages here, though, is that it also is not permanent, so the effect is going to wear off. So you are having to have repeated injections and treatments. It's also a higher cost, of course, because it's a procedure. Usually it's covered by insurance, but there is usually a process you go through, of course. Sometimes these treatments can be done with just giving a little localized medicine at the point where they're going to do the injections to kind of help with pain there. Or sometimes child life can come in and they can help with keeping the kids calm during these procedures. But for some of them, like with the phenol that we'll talk about, they do need anesthesia or sedation for those procedures. So how does Botox work? It's the botulism A toxin. And so basically muscle contractions are caused by a release of acetylcholine from the nerves at the neuromuscular junction. So basically where the nerve comes in and plugs into the muscle to tell it to move, that's the neuromuscular junction. And it communicates that again through this acetylcholine that's released. So Botox, it reduces muscular hyperactivity by inhibiting the release of that acetylcholine. So it prevents it from releasing and telling that muscle to stiffen up. So with Botox, most will start to see results within 5 days to a maximum of like 3 to 4 weeks after injection. So it's not an immediate thing. Again, the benefits are that we can have increased range of motion. Sometimes it can even help with pain if the kids are having, muscle cramps or problems from the stiffness. The effects can last anywhere between 3 to 6 months, but again, it's not a one-time thing that you have done. It needs repeated. And sometimes it has to be with sedation. Sometimes, again, they can do it with just some local medicine to help with the areas that they're going to get the injections in. Again, this doesn't really help with contractures, though. This is more for if you have a muscle where you have spasticity. So you can move it, but maybe it's really tight to move. Sometimes the kids, if they haven't moved for a long time, then they can develop what's called a contracture, where it's just kind of grown into that position. And so there's tissues kind of holding it in that kind of abnormal position. And so with that, loosening up the muscle doesn't really help because we've got other tissues there that have kind of grown into that position. And so with that, a lot of times they need some other procedures, sometimes surgery and things to help out. So some side effects of Botox, again, sometimes they can be kind of sleepy, they can be nauseous, they can have cardiac arrhythmias, DVTs, bleeding, muscle atrophy or fibrosis, so kind of shrinking of those muscles or kind of scarring. They could also be at risk of respiratory depression, depending on kind of where the Botox is given. And there are limitations for the kids about how much Botox they can have based on their weight. So for kids that have a lot of areas that they have stiffness in, sometimes they have to pick and choose which are the most bothersome areas that they want to inject the Botox in, because they may not be able to give it to all of the areas. I feel like most kids tolerate Botox really well. I haven't really seen a lot of these side effects, but they're certainly something that's talked about and should be considered. So phenol is another one that probably don't hear about as much as the Botox. So Botox is often given by some neurologists, it's given by orthopedists, and then also people called physiatrists or rehab doctors. Phenol, I feel like, is typically just given by the rehab doctors or physiatrists. So this is kind of more in the alcohol family. And so it basically, instead of turning off the signals between the nerve and the muscle, it actually kind of injures the nerve so that it's not able to send those signals. The nerve will regenerate, but it takes some time. And so in that time, the muscle's not getting the signal to contract. And so the muscles are looser. Again, the indications for it are kind of similar to how we use Botox. The phenol is often used for kind of larger muscle groups. And sometimes kids will have these in conjunction with Botox. Again, if they have a lot of areas that they need stiffness addressed, but they can't, they kind of are limited with the Botox, and they may use phenol in some of the bigger areas and, Botox in some of the other areas. Unlike the Botox, though, the phenol does have more immediate results because they've kind of immediately kind of injured that nerve, and it does last longer. It lasts about 4 to 12 months. The downside, though, to the phenol, downside to the phenol, though, is painful at the injection or with the injection. So they usually give this one with sedation. So that's the downside to it, is that it requires sedation. There's also something they've started doing in our institution called cryoneurolysis. And this is something that's kind of the thought behind it has been around for a while, and they've done it in adults, and it's kind of getting filtered more to kids. So basically, kind of like the phenol, where they're using cold to injure the nerve, so that they're kind of interrupting those signals down to the muscle. So again, it's the same principle that, injuring that nerve, it's going to take time for the nerve to regenerate. And so during that time, you have kind of looseness to the muscles. But in this situation, they found with the cryoneurolysis, it has minimal structural changes on kind of the scaffolding of the nerve. So it allows a better kind of healing or regeneration of the nerve. Whereas they feel like the phenol has a little bit maybe more chance to kind of injure the nerve a little bit more aggressively than the cold therapy does. The effects, again, like the phenol, are immediate, and it can last a little bit longer, though. So for some kids, this is lasting up to 12 months. This does require anesthesia or sedation because it can take a long time. They have to use this little gadget here and put it on the nerve and then hold it on the nerve. And they told me it can take up to like an hour for one leg. So if they're doing 2 legs in kids, this becomes a 2-hour procedure. Um, they can use it for pain control as well. If there's like a nerve that's causing nerve pain in a particular region, they can also use it for that as well. So it's a pretty nifty new treatment. We've had about 30 kids at our institution that they've tried us on, and they've seen some really good results. This can also be used for kids that have a movement disorder where they have extra movement. If you've seen some kids that have that where they can't control the movement of an extremity, this can also be really good for that. I saw some videos they showed me of a little girl who couldn't handle her arm at all, and immediately afterwards she was at rest, and so it looked amazing. Again, this is just kind of showing kind of that principle of here's the nerve with its branches and connections down to the muscle here, kind of telling it to move or contract. And so we're giving the medicine that injures the nerve, and then it's going to take a while for that nerve to kind of regenerate and build back its connections to the muscle. And so with the cryotherapy, it's kind of doing the same thing, but it's doing it with these touch points of this extreme cold therapy to kind of interrupt the nerve. And then there's something called serial casting. And sometimes we do this in combination with a lot of the procedures that I just talked about. So kids that maybe have a really tight ankle where they're kind of in a position where it's even difficult to get them into a brace. And maybe their toes are so pointed, it's really hard to get them into a brace. Sometimes they'll do things like the Botox or phenol, any of those that we talked about to kind of help loosen that up. And then they may do something like serial casting. And so basically with serial casting, if you ever had a broken bone and you had a cast put on, your arm came out and it was real loosey-goosey and kind of looked all small and weird. So basically we're kind of using that principle that if we keep you in one position for a while, we can help kind of stretch out that joint. And so what they'll do is they'll put on these temporary casts. Usually the therapists are the ones that put them on. They'll kind of stretch the arm or ankle or whatever out to a certain point that it can go, and then they'll cast it for a week, and then they come back a week later and we've kind of gained that range of motion. So now we'll push it a little bit farther and keep doing that until we can get to a better position, and then they might go in and do more permanent like AFOs. This is not a permanent thing, though. It's not a permanent fix. It helps you kind of regain that range of motion that you may have lost, but then we have to kind of keep it up with the medicines and other treatments. But you can see in this example kind of where they started and where they ended up. There's also intrathecal baclofen pumps that are used for spasticity and dystonia, some of those movement disorders. So baclofen is a medicine, again, that we talked about that you can take by mouth. But again, some people have problems with a lot of the systemic symptoms that can cause, like they're having problems with the sleepiness and things like that. And so in this situation, it's an implanted device where it actually just administered the baclofen right into the spinal cord area called the thecal sac. And so with this, they can use lower doses than what they have to use orally because it's kind of going directly into the area that it's needed. And doesn't have to get kind of processed through the GI system. And so again, there's potential for less systemic side effects. Downsides to this, though, I mean, there can be problems that it does require surgery, of course, so that's a big deal going under anesthesia for a surgical placement of this device. It is expensive, again, but it's something that they would get approved with insurance. There can be problems that sometimes if the tubing can get dislodged or kink can cause problems. Sometimes if you can have a baclofen overdose if there's a malfunction of the pump, or you could have a problem with baclofen withdrawal. Again, if you have a malfunction of the pump, or say you just run out of medicine in your device, like you didn't get in there to get your pump refilled. And those can also be severe symptoms that sometimes the kids end up in the hospital for. So it is something that definitely has to be managed carefully. There's also the risk of infection anytime you have some implanted device in. There's always that risk there, but I feel like we don't have that much. Again, this is reversible, though. It is a surgical procedure, but it is something that can be removed. And then I just want to talk a little bit about equipment. I know that's not really a procedure, but I think it's something that is really helpful for the kids. So there are things called standers for kids that are not really walking but are not mobile. So it can help kind of hold them in an upright position for a child that's maybe not able to do that on their own. And then there are also gait trainers, which with this, the kids, again, it has more support than maybe just a regular walker for their trunk, but they can take steps with this one. And so, being in the upright position is really helpful for our bodies. So it can help, putting some weight on our feet and our joints can help with bone strength or density. If you have problems with not being able to be as mobile, you can also have kind of slowing down of the gut. And so sometimes being upright and being mobile can help with constipation and gut motility. It's also great for the kids. They just get a new perspective. I mean, you can imagine if you're laying down a lot or in a chair a lot, being in a new position and kind of seeing the world a different way can be great. Some of the kids, they just really like to be standing in an upright position. And a lot of these have like kind of trays or tables so they can have some activity there to kind of keep them busy. Again, also being in the upright position kind of helps with their breathing and also kind of with speech and secretions if they're in a different position. And then it also gives them another opportunity to kind of get off of those areas that they're usually putting weight on. So if they're kind of sitting in a wheelchair a lot, they can end up with pressure sores and things from being in that same position a lot. So having an opportunity to kind of be in an upright position where we're taking the weight off of those areas is good. And it also provides more opportunities to kind of do their social skills. So if the kids are able to kind of take some steps and walk around and explore their environment more, or if they're just upright and more engaged with the other people around them, then this can be great for them. And just since it's summertime, I just wanted to put in a little plug for some of our alternative therapies, which would be like aquatic therapy. The kids love getting in the water and swimming. And then also hippotherapy, which it's not with a hippo, it's with a horse, but this is another great one. And you can do like this little kid is actually doing occupational therapy on the horse. Kids will do physical therapy. I've seen kids do speech therapy. Sometimes just being around an animal really engages the kids and they're much more open to doing therapies than they normally would. And sometimes they'll also do like occupational and physical therapy with aquatic therapy as well. But I think summertime's a good time to kind of look at doing some of these other things when they're maybe not in their school therapies. So, and a lot of times they're covered by your insurance, at least in Georgia. I know we have to kind of, some insurance plans make you pick or choose. They won't let you have both of them. But if you've got good insurance, maybe you can get both of them. Any questions that y'all have? I did so well. There's no questions. That's awesome. Thanks. Do y'all have any comments? Anything you want to tell for other parents or anything? Anything I missed or you guys want to share? No? All right. I'll let you guys get to lunch. Thank you.